Buenas tardes a todas y a todos. Con el permiso de nuestra señora directora y con la presencia de nuestros distinguidos asistentes, me honra presentar a nuestra ponente. Me presento primero yo soy el doctor Alejandro Molina López, soy psiquiatra, maestro y doctor en ciencias, orgulloso egresado de la Facultad de Medicina y orgulloso profesor de pregrado y de posgrado de esta Facultad de Medicina, y actualmente como presidente de la Asociación Psiquiátrica Mexicana me complace presentar a la doctora Danuta Wasserman. That I will present to you. Thank you very much for being here. Dr. Wasserman, it's a real honor to be here in our school and in this particular day, and to have choose our country for the 24th World Congress of Psychiatry. I will tell your bio in Spanish, and after that we will be delighted to hear you. Thank you very much. But not too long, okay. Voy a presentarles la biografía. Ella misma me dice que no sea demasiado extenso. Va a ser un poco complicado porque sí es una biografía bastante extensa y bastante sobresaliente. La doctora Danuta Wasserman es actualmente la presidenta de 2023 a 2026 de la Asociación Mundial de Psiquiatría. Ella es de origen polaco, pero actualmente reside y trabaja en la Universidad de Karolinska en Suecia, y ella a su vez ha tenido varios cargos académicos honorarios. Ella es profesora de psiquiatría y suicidología en el Instituto Karolinska en Estocolmo, en Suecia, y también ella es fundadora del Centro Nacional para la Investigación de Suicidio, y ha colaborado también con la Organización Mundial de la Salud en varios programas. Ella también es la expresidenta de tanto de la Asociación Europea de Psiquiatría, que implica 44 nacionalidades, y también ella se ha dedicado ampliamente a la promoción de la salud, y como suicidóloga, pues tenemos un gran privilegio de tenerla el día de hoy. Doctor Danuta Wasserman, please, we will be delighted to hear you. Thank you very much.
Thank you very much. It is a great pleasure to be here and to have the opportunity to speak about mental health and suicide prevention. It is my disclosure statement. We need to do it every time we are presenting something. So I am involved on research in young people. Why I am showing you this National Center for Suicide Research and Prevention in Stockholm, Sweden? Because it is important to have a dedicated body to one topic. We were acting since 1993. It means since 31 years ago. And we have a very good results in collaboration with the World Health Organization and our national government, and have opportunity to serve really as experts on prevention, treatment, and rehabilitation in suicide prevention. As you see, there is a golden medal of Nobel. The Karolinska Institute is awarding each year a Nobel Prize in Medicine and Physiology, and working so closely with colleagues who are working on this committee is also very rewarding. Firstly, I will tell you something about the World Psychiatric Association, because you are the neighbors of United States, and everybody thinks that American Psychiatric Association is the biggest one. It is not. It is one of our members. And also in Europe, there are those misconceptions that United States is the biggest country. They are funding a lot of research. They have excellent research, many psychiatrists, but they are a part of the bigger community of 147 psychiatric associations from around the globe. And Mexican Association is one of very active, and because of that, I am very happy we can have a World Congress starting in a few days here in Mexico City. Our mission is, of course, to promote mental health. And what is mental health? Mental health is not the opposite of mental disorders. Mental health is important for everybody, every one of us. And the very good definition of World Health Organization is that everybody who possesses mental health, they can cope very well with stresses of life, realize the abilities they have to cope. They can learn well, work well, and contribute to the community, which means you need to connect, function, cope, and thrive. And remember this definition, because it is extremely important for the global population. The global prevalence and burden of mental disorders is quite huge. 1 in every 8 people, 13% of males, 15% of females, have some kind of mental problems or mental illness. And the biggest ones are, if you look at the circles there, are anxiety disorders, depressive disorders, and you can see the small circles are about schizophrenia, bipolar disorders, and mental disorders. They are dealing with mental health problems. What is a big problem? That only 2% of health expenditures go to mental health globally, which means it is 50 cents per person on the globe, and it is absolutely not sufficient. So it is really very important to lobby for more funds to promote mental health in societies. We know that people who have mental illnesses, mental health problems, they die 10 to 20 years earlier than general population. There is a great comorbidity with somatic disorders, as well as with the lifestyles, for example, sedentary behaviors, lack of physical activity, poor sleep are connected to poor mental health. We know also that pathological internet use is connected in bi-directional way with mental health problems, especially anxiety, depression, conduct disorders, hyperactivity, inattention, and also with suicidal behaviors. We know also that treatment efficacy for most important mental disorders done on 50,000 patients shows that both pharmacotherapy and psychotherapy have very similar efficacy in the treatment, but we also know that we usually need to combine those treatments, and we know also that we need to have better treatments, but they are very expensive to develop independently if they are pharmacological or psychotherapeutical. We know also that it is a great mental health treatment gap. And in some low and middle income countries, 90% of people have no access to treatment, in some on the Asian and African continents especially. What we also know that we need to adopt a life course approach to health and mental health, because 50% of mental health problems are established before the age of 14 years, very early, and 75% below the age of 24 years, which means that we cannot wait and see and do nothing with our children and young people. So what we do in the World Psychiatric Association, we are trying to implement all evidence-based therapies. I will come back to that. And we work eagerly with mental health promotion and prevention for all on the globe, and on adoption of healthy lifestyles already when mothers are pregnant and fathers are waiting children, very, very early to the late age. We will have on our website lectures which are called Advances of Science and Their Application in Clinical Practice. It will be the specialist corner, but not with the ordinary lectures like mine. It will be a short lecture on the main topic, let's say depression or schizophrenia or attention deficit disorders. But we gathered very good expert groups from around the globe, because my motto is to have equity, equality, inclusion, and culture, which means that we need to have all genders in our groups. We need to have people from different cultures, and we need to include them in our work. And they will give us feedback during those lectures on important issues of public mental health, people who live with experiences of mental health problems, caregivers, human rights and ethical concerns, and also how to use digitalization to better reach to everybody on the globe. So remember, we are also trying to reinforce existing treatments with promotion of healthy lifestyles, because healthy lifestyles, as I mentioned, physical activity, good diet, sleep hygiene, the good environment, they improve our both physical and mental health and quality of life. And the target groups are not only psychiatric patients or the population, general population, but also within the general population, we as professionals need to apply those skills as well, because we are not living very good and healthy lives. Maybe students do it, but not teachers. So we have a hub on our website about healthy lifestyles, physical activity, and different kinds of films with 3 levels of difficulties to use in ordinary clinical practice with your patients as a doctor and a staff, because it will also break the barriers between the patient and the staff, and also give the staff possibility to use working hours for improving their mental health, because you cannot easily go to gym during your working hours. In some places, yes, but not on many places on this globe. But when you do it with the patient, it is your work and you are promoting your own health as well. We have also videos about how to eat and how to discuss with young people their eating habits, and how to choose food when you are shopping, what to do with leftovers, and how to preserve them in order to improve climate on our globe. So please look at this website and maybe you can utilize something of that in your ordinary life or work. Those are added principles in psychiatric practice and research. And I will not speak more about it because I already mentioned about equality, etc., etc. I would like shortly to show you how much you can do in suicide prevention. When you look at this slide, you can see that Mexico is not so bad off concerning mortality in suicide in comparison with the global figures, or figures from African region, for example. They have tremendous problems for males in suicide, and there are very few colleagues or public mental health people who are working on those issues there. In Mexico, you are working, Alejandro Molina, we issued his book on suicide prevention in Spanish, so it will be easy to read. What is the big problem is suicide rates among young people around the globe, because after road accidents, tuberculosis, and some cancers, suicide is very important cause of death for young people. And we have factors in suicide prevention which we can modify. and some of them are not modifiable, like age, sex, genetics. Genetics to some degree, yes, because we can trigger some genes or we can slow down some genes. So it is, to some degree, it will be modifiable. Ethnicity not, and family history and childhood trauma we must live with. But there is a lot what we can do about treatment, rehabilitation of psychiatric disorders, about loneliness and social isolation, coping problems, housing, access to lethal means of suicide. What is important in this context, at the university we can see very often among students who are studying the first or second term that they can be depressed, get suicidal thoughts, or kill themselves. So it is very important to have preventive programs for the students who start, but also for the students who are leaving university and they have a lot of uncertainties in front of them. I spoke about genes, that in suicide, 50% of factors are environmental factors, and genetic factors are responsible, together with stressful life events, for 50%. I would come back here because the genetic factors, we studied them for many years with my group, and we can see that they are factors on HPA axis, stress axis, and especially for males who have more completed suicide than females. Especially males are reacting to stress to much higher degree, even if the stress is not measurable always with the instruments we have, because of some genetic inheritance which females are protected from. We don't know exactly which genes yet, but we know that they are genes on HPA axis. The other factors are neurodevelopmental genes. So why I am saying already, when family is waiting a child, you must have a healthy life, because during those first weeks, you are influencing the genetic setup of your children. There are many evidence-based suicide preventive strategies from the public health perspective and from the healthcare perspective. And I will very shortly show you what you can do from the healthcare approach. You can treat. It is important to have a good chain of care, which means not have care in the pieces. You need to have very good chain of care from one stage to another when the patient is in the hospital or in the polyclinics, and when it goes to the community, it must be excellent communication between those different parts. And we can also educate our primary care physician and our communities as well. We know that lithium and mood stabilizers work for bipolar disorder, antidepressants in depressive patients, and clozapine is a very good antipsychotic treatment, but they should be combined with talkative therapy, of some kind of talkative therapy. You know also that there is a risk for treating suicidal people with antidepressants, because antidepressants during the first days and few weeks can trigger suicidality, because they can trigger anxiety, and anxiety is very important driver towards suicidality. So because of that, supervision and active follow-up is very important, and combination with psychotherapy. We have very many psychological treatments which are evidence-based and which work. Cognitive behavioral therapy, dialectical behavioral therapy, family-based intervention, and even psychodynamic psychotherapies. Crisis response safety planning is extremely important for the patient, for the family, for the community, and the doctor who is taking care of patient. What are public health approaches? public healthcare approaches is firstly responsible media reporting, because irresponsible media reporting can trigger vulnerable boys or girls, especially young people, or adults who are vulnerable, to repeat the same act the media are reporting about. And they are excellent World Health Organization's media resources. What media should do and not to do is excellent research on that, showing that there are bad effects if you don't follow these guidelines. Restriction to access to lethal means is important. So you must be sure when you have somebody who is depressed in the family or a friend, you should take away firearms from homes. It is very important for United States. And I know that in many child and adolescent clinics, doctors are saying to parents, make sure that you have no gun in home when you have depressed, anxiety-driven, suicidal kid at home. Pesticides in the low and middle income countries, medications, locked closets for medications. Railways and subways are hotspots for suicide. And we know that psychiatric hospitals and maybe also universities, if you have closeness to the railway, some people who are in despair will jump or can jump. And they are successful programs how to monitor and how to approach this kind of means of suicide. We need to reduce the harmful use of alcohol and drugs. And we have very many good school-based interventions. 2 are from United States and 1 use aware of mental health is from Europe, with very good results. And some of them are very well implemented in some European countries and also in some states of United States and in Australia. I am not going to show you this study because I have not so much time and maybe you have some questions. But with that study, I mentioned use aware of mental health. We could see that we could decrease incident numbers of suicide attempts and severe suicidal ideation by 50% and incident cases of depression by 30%. So they are very good results. And they are built on empowering young people in the ages 13 to 17, how to cope with stresses and how to seek help and with whom to speak. And the mechanisms are on increasing knowledge, increasing help seeking, and also the guilt and shame is taken away in this program from the classroom. Teachers are not involved. We have people who are coming from outside and running this program, because if we have teachers in the classroom, children are afraid to disclose difficulties because they want to have good grades to progress in the education and not show vulnerabilities. We could also see through very thorough investigations of psychological components of personality that impulsivity and violence was decreased with this program. I mentioned before that healthy lifestyles are important, but even more important is that we are aware and work for the United Nations 17 Sustainable Development Goals. People are laughing, politicians are laughing at those goals, but those are very important because health, somatic health, mental health, and well-being depends on the criteria we have in those goals. It depends on environmental goals about working against climate change, to have good life in water, good life on earth, green spaces. They are also economical goals, no poverty, no hunger, and to have good working places, and also to build on innovation and infrastructure in order to give better wealth to the entire society, and also social goals to have not only equality and equity, but also peace and justice and strong institutions. And there are very many research papers on each of those goals showing how they are influencing the somatic health, mental health, and well-being of the society. So our action plan is built. I am not a politician, but WPA needs to have an ideology, not only the small one to treat schizophrenia or depression and improve mental health, but we need to influence our politicians, we need to influence our administrators and our profession to change the profile, how to work on mental health with the communities and local government. So thank you very much. There are books in English, but you have very good in Spanish now, so I don't need to show it. And this is picture of Stockholm and the invitation to the Congress. Thank you.
Thank you very much, Dr. Wasserman. I would like to ask to the auditorium if you have some questions for Dr. Wasserman, algunas preguntas que puedan hacer. Doctora Sepúlveda, por favor. Tienen que dar un micrófono, por favor, que acerquen a la doctora Sepúlveda, por favor.
Well, thank you very much for your presentation. It was a great one. I wanted to ask you about your experience with artificial intelligence and chatbots in the identification of suicidal patients and first responders as in the chatbot.
Yes. There are very many ongoing research activities on it, because it will be of great help, especially if we can do not static judgment, but dynamic judgment, and follow the patient in dynamic way, which means maybe from hour to hour and day to day, because suicidality is not constant. So if you only put to chat box the risk factors and protective factors, they will never predict suicidality, which means that you need to put data in life in order to have a good help of artificial intelligence and also doctors. But we have no possibility to make this kind of follow-up. We can see patient maybe in the acute stages every day, but not 24 hours per day. So it is a great future for that.
Thank you. Yes, doctora Joyce Bustos, por favor.
Well, thank you very much, Doctor. It's an honor to meet you. And my question is, at what age do you consider could be a good age to initiate with this kind of prevention programs here in Latin America?
As early as possible. Can you hear me?
Yeah.
As early as possible. And to put it into play, because it is very important to have it not like military training, but the play is very important for the development of child. And also play for parents is important because it must be enjoyable. And you know, there is so much fantasy everywhere in every country to put it in the cultural context. So start as early as possible during pregnancy for mothers.
Thank you. That is because, it is important, for example, to believe, for children to believe in Santa Claus and things like that, right? I mean, about having the capacity of believing in something else.
Yes, exactly.
This kind of spirituality and be able to believe right?
Yes,
It's like
exactly. To have leaders for this kind of activities, and also network for leaders, because leaders and we therapists with also professional networks to develop and to have debriefing and psychological help.
yes, there's so much to do. Thank you very much.
Sí. Doctor. Ujú. El doctor, por favor.
Thank you so much for the talking about this day, Doctor. And I have a big question for you, but I want to explain so that the work here in Faculty of Medicine that has a mental health program called PROSAM, which provides clinical support to the community and conducts suicide prevention courses. These courses are designed to help the students and staff identify individuals at risk and reduce this risk by connecting them with specialized services. Additionally, the program is developing a response protocol for suicide attempts with the goal of training the community to intervene effectively in cases of emotional crisis or imminent suicide risk. In recent months, we have also visited student classrooms to assess their mental health needs and provide self-care and emotional regulation strategies. In your opinion, what interventions do you believe will be most effective and adaptable in settings with medical students on work to help people and to prevent or reduce suicide risk?
Yes, a very good question. On our website, World Psychiatric Association, I put one suicide preventive project, which is called BIC project, BIC, Brief Intervention and Follow-up or Consultation, we call it, which we developed with World Health Organization in 2008. The results were published. And it's a little bit similar to that, what you are saying, what you are doing in the community, in the classrooms, but this one is in collaboration with the hospitals. When they are discharging suicide attempters from the hospital, it is very important with a structural follow-up. And previously we saw that 3 months maybe is enough, or 1 week maybe is enough, or 3 weeks, or 6 months. This project with WHO was run for 18 months, and we could see very good results, not so very, how to say, intensive follow-up after 6 months, but still giving security to the family and the suicidal persons that there is somebody who cares. And this follow-up was done by medical students or psychologists or nurses in collaboration with doctors from the hospital, because the aim was to give the signal to the patient, you are not alone. The second signal was comply with your treatment, because usually our experience is that our patients are not complying with the treatments we are prescribing, and it is very important for the success. And then also how this person can be integrated or helped within the community. So there is a lot of do for medical students and psychology students and nursing students, and there is the whole protocol on the website. And in a few weeks, we will also put video showing training the people how to make follow-up, done by Natalie Riblet from United States Veterans Administration, because she was working and researching this WHO project for quite a long time. So she has experience, and we asked her to put the video, so you can use it. And there is also methodology if you would like to make scientific paper, a small paper, pre and post measurements. So to combine not only practical issues, clinical issues, social issues, but also to maybe do some follow-up for your hospital and publish.
Thank you.
Okay, I understand that there is an online transmission in social media and YouTube. I don't know if there's some questions there, and we will continue. Please, Dr. Jacqueline, and after this, please, and Dr. Jeremy.
And you have somebody on the next second row also.
Okay.
Yes.
Okay.
Thank you so much, Dr. Danuta Wasserman. For me, it's a pleasure that you be here. And I'm very happy that you can teach us the skills, because I am coordinator the program of the mental health, the clinic, and we attend all the faculties, as you know, and we are going to pay attention in the patient, in all the skills that we can put in action for our students. And I just want to say thank you, because you choose Mexico City for the 24th World Congress of Psychiatry. We are going to have 3,500 attendees at least. We have more, and it's really for us an honor that you choose Mexico City for the World Congress, because it's not very common. So we are happy about that, and I hope that everybody can go to your Congress. Thank you.
Thank you.
Thank you very much. Dr. Jeremy, and
it was an amazing presentation, but I need to ask you some questions about your implementation of programs. At the first time is like, we are living in a middle income country, and we have problems of the low income countries in 60% of population, and we have the same problems of high income countries in Mexico. And you tell us about the school and the importance of mental health in schools. Which is your proposition, or which is your plan to get there? Because we are only maybe 4,600 psychiatrists for all the country. We have a lack of psychiatrists in public services, about 90%. And to prevent suicide, it's important that we need to work and we need to apply part of our work in implementation and in programs with other non-psychiatrist workers or in other non-mental health workers. What, in your experience, it's necessary to do to get to the school?
Yes.
Sorry for my Paulina.
No,
Ruby voice.
it is a very important question. I can tell you have the Minister of Finances. He knows very well how to promote mental health in the populations, because he worked, Professor Jose Ramon de la Fuente. He worked with the United Nations on the rights of people with mental health problems, how important it is. And I'm sure he is also aware how important it is to start early in that what you were saying about not only suicide prevention, but promoting healthy lifestyles and also coping styles in families, and to work, as you say, with other sectors in the society. And probably, we don't even need to have a screening, because we see very well children who have problems, and not let those children to be with those problems for a long time, but really to have a good psychological and family therapy help in order maybe not to treat, because sometimes it is not possible to treat, but to learn them to cope, how to cope and how to achieve life goals which are adequate for the state of health and well-being of family and the child. So there is a lot to do on the mental health promotion in the society, and then picking up groups or individuals or young children or school children. Because, in schools, everybody knows where is the problem. So you don't need to have very qualified screening instruments. When I started this Youth Aware of Mental Health project, it was in the 80s, with a nurse and psychologist in the secondary school and gymnasium in the district I live. And they had problems in the classrooms, and they started to work with the classrooms by making retreats with the entire classroom for one day or 24 hours and working through the conflicts in the classroom. And the results were amazing. I was evaluating that project, and I was looking what effects they had. And they had effects on suicidal behaviors, and they have effects on the connections in the classroom and respect for each other and taking away the stigma, which means that you can do a lot in this healthy situation. They were not professionals. They were ordinary school teacher and school, not even psychologist. One was nurse and one was a social worker. And they had this wonderful intuitive program how to resolve conflicts in the classroom, which I think is extremely important in socialization and giving the coping styles to children and young people.
Okay. We have two more questions. Here, no tengo el gusto de conocerla, si puede presentarse, por favor.
Thank you very much. It's a great presentation. I'm Abby Casas from National Institute of Pediatrics. I'm a pediatrician. So we are trying to develop a model to give a good attention for children, since we had an increase lately in the last 3 years. We had 4 times more than we used to have children arriving with suicide attempts. So I would like to ask you some advices regarding one of the main barriers that we have to make research with children and adolescents are the parents, because we need to get informed consent from them to let children participate and to be screened and to let us to make some interventions. So we have seen and we have worked too at schools, in some high schools with young adolescents, but the main issue and the main barrier is our parents or caregivers. And another question that we would like to ask is, we are a reference hospital, so children come from all the country. So sometimes we don't have enough time to keep them to start a treatment. Which strategy would you recommend us to make a very short intervention to be effective and to try to keep them as safe as possible in the short time that we have them before we are going to refer them? One of the disadvantages of referring them is that we are not sure they are going to have access to this attention, because parents sometimes they don't do that, or they don't have any service near from their home. So those are my questions. Thank you.
Yeah, yes, there is a very great problem with referring somewhere, because when we have done our studies in Stockholm, which is 1 million city, or 1.8 million is nothing in comparison with Mexico City, we could see that if the surrounding institutions were not prepared, they were not follow up, and there was nothing was happening. What you can do in the short run is to try to teach those children a healthy lifestyle. If I understand you correctly, you have them during some period of time in the clinic, yes? I don't know, 2 weeks, 3 weeks? Not even that?
1 to 4 days.
4 days is already better than 1 day. So it is very short. But I mean to teach them something what they can take home with them and share with parents. Because in our programs, parents were very interested. It was written information, what we were doing with the children in the classroom, and it was a very good point of discussions, because parents very often, they don't know how to approach the child, especially the sick child or negative child. So give this kind maybe of information to families, what they can do with children, and to teach them how to communicate and about healthy lifestyles. I think it is a good short-term program to try to evaluate on behavioral changes and emotional changes.
Okay, thank you. We have a few questions, and please, and then we will finish after that.
Hi, thank you, Doctor, for your conference. In a context like Mexico, where one of the main stressors is poverty, which explains why the population cannot treat themselves. They travel hours to get to work or to university, like here in Ciudad Universitaria, earn less than $20 a day if they are working, and live in the outsides of the city. I mean, like, well, maybe you don't know Mexico City enough to tell you like they live in Xochimilco or something like that. What will be the recommendations to improve their mental health, taking into account this particular context of poverty?
Taking
I mean,
into account what?
In a particular context, she says that what do you do in a particular context in some place in Mexico City, such as Xochimilco?
no. I mean, what do you do? What are the recommendations to treat your mental health if you're living in a context of poverty?
Yes.
Like,
yes.
it's not that you don't want to treat yourself, it's you don't have the
Yes.
time to do it.
That's a very important question, because the latest reports, they say that 40% of the world population is living in poverty, 40. So the goal of achieving lack of poverty in 2030 is not available for us. The problem is that previously poverty was counted $2.50, I think, per person, and now it is $4 or $5 or $6 because the levels of standard are increasing for the global society. So still 40% are poor in comparison to the level of the society. You know, it is very difficult to give advice if you are living as we are living in privileged conditions. So I think that the most important is to have some kind of the participation programs from the communities which are poor, and together with them to work on methods to share our knowledge and to get help from people who live in poverty, how they can achieve, how to eat better. Probably eating is very important, what they are buying and what they can afford to buy, and to have a good advice to buy in relation to that what they can afford, as good products as possible for the health of adults and elderly and children. So I think that eating habits could be very important. And then you maybe need to work with the industry and the restaurants also to have this kind of healthy food. They are, in Europe, they are very popular. They are putting calories and everything on the menu. So, I mean, I think it is possible, but I am very humble to recommend something to the communities which are very poor, because I think we need to have participation in developing programs with those communities.
Ok. Bueno, ¿tenemos tiempo para preguntas? Sí, por favor, one question more. One more question, please.
Well, first of all, thank you for your talk. And my question is next. What are the risks associated with receiving psychotherapy not based on scientific evidence? Because at least here in Mexico, we don't have like the best on ethics. And for example, we're still treating people with psychoanalysis. And that's a thing that I'm worried about. What are the risks about doing this? Thank you.
Yes, we have in each country, we have quality indicators for the professions who are giving treatment. So the risks are, I wouldn't say only with psychotherapists. The risks are also with doctors who are giving pharmacotherapy. So we have the same risk. So they are quality indicators, how to control and how to follow up when a professional psychologists or psychiatrists are pursuing treatment, and increasing awareness of patients to see or to report if they feel negative effects or they are not treated well by therapists. Concerning psychoanalysis, I am not so critical by myself. I have a psychoanalytic training, and many of those wonderful therapies, which are evidence-based and very well researched, are based on psychoanalysis. For example, cognitive behavioral therapy was developed by Aaron Beck with his psychoanalytical training and base. So I mean, but of course, in each treatment and in each profession, you have excellent people and you have bad professionals. And in the middle, we are, most of us, 80% are doing a good job according to the standards which are important. So it is more for the quality assurance and indicators how to follow up our professional work.
Okay. Well, we don't have enough time for all the questions. I would like to really thank to you first. Thank you very much. It is very important to have you and to hear about this important issue, this important thematic. And I really want to say thank to Dr. Ana Carolina Sepúlveda. She, thanks for her, we have now this express conference. We are very happy to have you here, and I think your visit, your quick visit, will be very inspirative for more and more professors and students. And I would like to ask you one final question. Many professors have fear about suicide. They just doesn't know how to do if a student tell him or her, well, I want to kill myself. And they just don't know what to do. And what would your advice for that professors in order to not have a fear, that don't be scared about suicide, and to be a companion to a student or a person that has some suicide thoughts? What would you advise?
Very important question. It is not only teachers, professors, but everybody in the society is very afraid of suicide, because suicide is violating our self-preservation drive. Yes, we are working for life, and we are living to live, and it is really against our natural drives. So almost everybody is afraid to ask, because it can be a trouble for me. Maybe I can evoke something. But remember, we are not evoking anything. The suicidal thoughts exist already. What we need to do to learn from our maturity or our experience, to listen and to show attention, not acceptance, but attention, because it helps a lot how we answer to person who is suicidal. We need to listen, and we need to secure that this person is not left alone, which means that very often we need to have some time to speak with this person. We cannot fix it in 2 minutes or 5 minutes. It maybe will take from us half an hour to listen, to find out if there are any resources I can use for that person. So it is not an easy fix, and it is very important question, but it is better to ask, better to listen than not, because it influences also our mental health. We don't feel very well if we know or feel that something is wrong and we are not acting. So for our own self-preservation, our own mental health, it is really very important to listen, not to give advice, to listen and to try to broaden very narrow sight of suicidal person, and during the time to think whom I can engage, which means that you maybe need to have between colleagues also discussion. Who at the university can help me and whom can I ask to have a small role plays to see. I remember when I started with my project and I had professors in different teaching activities and asked them to be a suicidal patient or be a suicidal doctor, how afraid they were on the stage to speak about it. So it is not something coming naturally with us. It's a very difficult topic, but it is something we need to increase awareness about in the society, already in schools, to teach in schools, in medical schools, and earlier also, how to speak about it. And so these programs for young people are quite good because they learn how to listen to the peers, and they dare to give advice, and they dare to interact. And in the classroom, you have very clever students on the one and very stupid students on the other, and very normal students in 80%, yes? And everybody has own experience, and those experiences are resonating in the classroom. And in these programs, afterwards, students are speaking in the dining room, and they are speaking with maybe parents or older or younger peers. So it has secondary effects of working on that, what you learned in the classroom. So the same here, to have some kind, Jacqueline, at the university, some kind of talkative group on difficult cases, of students with mental health problems. How should I act and what I can do? It was a very important question because it is the most difficult question for everybody. And thank you very much for inviting me. I don't.
I am writing homework.
Yeah, that's very good. Yes. And I am very happy to have a young audience here and very active audience because it will leave some traces also and some thoughts for the future.
Thank you very much.
Thank you.
Well, I will finish this conference in words in Spanish. Lo que dice la doctora Wasserman sobre el suicidio, cuando alguien dice que se quiere suicidar, es mejor escuchar que no escuchar y es mejor acompañar que dar un consejo. Eso es muy importante para todos los profesores que en alguna ocasión nos aborda algún alumno o alumna que nos dice quiero suicidarme y tenemos miedo. Simplemente lo mejor es escuchar y acompañar que no hacerlo. Thank you very much, Dr. Basser. Está aquí el doctor Carlos Gense. Carlos Gense is a reporter of health, and he wants to make a
Thank you, doctor.
Reporter of health in Mexico.
Yeah,
Journalist.
Thank you. Okay, it's only for the one words about the next Congress. Si puede darnos unas palabras del próximo congreso que va a haber, para invitar a las personas que participen en el congreso que va a haber, si es posible.
Claro. Carlos Gense is talking about we will have the next World Congress of Psychiatry in Mexico City, in our Mexico City, from 14 to 17 November, pasado mañana. Vamos a tener un congreso mundial de la Asociación Mundial de Psiquiatría en la Ciudad de México, en el World Trade Center, y la doctora Danuta Wasserman nos escogió como sede y estamos muy agradecidos por eso. Entonces los esperamos en este Congreso Mundial, 24º Congreso Mundial de la Asociación Mundial de Psiquiatría. Thank you, Dr. Wasserman, for choose Mexico. Mexico is very proud and Mexico loves you. Thank you very much.